The slides.
All right, can we get started then? Yesterday we had discussed about COPD. The day prior to that, we had discussed in detail regarding asthma. And we know by now that there are three airway disorders: asthma, bronchiectasis, and COPD. So let's look at what is bronchiectasis at this point of time. Bronchiectasis is another chronic airway disorders characterized by lung inflammation, impaired mucociliary clearance, accompanied with recurrent bacterial infections of the airways. Now, the hallmark that distinguishes bronchiectasis from COPD is that the damage to the airway occurs from repeated infection, not from an outside noxious stimuli. This leads to permanent damage of the airways. So bronchiectasis is destruction of the airways with repeated bacterial infections, fungal infections, leading to scarring of the airways. As such, just like COPD, it is an irreversible process. Bronchiectasis results in significant cough. And if you remember the first lecture, it is associated with sputum production as well. In fact, of all the three airway disorders, bronchiectasis has the largest amount of sputum production and sputum purulence. We had also discussed at one time that it is associated with significant hemoptysis. On clinical examination, bronchiectasis patients have clubbing. I mentioned clubbing in COPD. I said uncomplicated COPD does not have clubbing. Clubbing occurs when COPD patients have either lung cancer or they have developed pulmonary hypertension. But in bronchiectasis patients, long-standing bronchiectasis is associated with clubbing as well. On clinical examination, these patients have not only expiratory wheezing, but tracheals as well, slightly different than the first two airway disorders. The test of choice for diagnosis of bronchiectasis is CAT scan of the chest. On spirometry, you will see obstructive lung defects, just like you would see in COPD. So what causes this kind of destruction? We believe these patients are at risk for bacterial colonization because they have abnormal mucus clearance. Now, the airway lining has cilia, which move the mucus from the lungs. Either we swallow it or we absorb it in the airway lining itself. If the mucus clearance is impaired, the mucus accumulates in the airways. If it accumulates in the airways, it becomes like a petri dish or area where bacteria can colonize and grow. When bacteria colonize and grow, what attacks these bacteria? Neutrophil elastase and things like that. Same kind of destruction sometimes results in damage to the airway epithelium as well, and you get destroyed airways, and that's what we call as bronchiectasis. So this was a hypothesis: abnormal mucus, bacterial colonization, predominant of neutrophilic inflammation from neutrophil elastasis, airway destruction, bronchiectasis, and it's continued. Now we believe it's just not a single process. Abnormal mucus can lead to neutrophilic inflammation. Bacterial colonization leads to more infection. So it's a multiple pathways that are occurring in the airways of these patients, ultimately leading to damage. So the so-called pliable airway lining, the tube, the trachea, the bronchus is no longer a straight line. It is destroyed in many different forms and shapes. And as such, then once it is destroyed or and the anatomy is disturbed, patients can no longer cough out the mucus as efficiently as before. So it's a vicious circle. To recap, just for the uninformed, that I feel that this group probably knows, the difference between the COPD and bronchiectasis, one last time. COPD is cigarette smoking, like bronchiectasis is infections. The role of infection in COPD occurs during exacerbations, and the three bacteria are H. influenzae, Streptococcus, and Moraxella catarrhalis. Whereas in bronchiectasis, the bacterial colonization leads to different kind of bacteria, generally Pseudomonas, staph, some H. influenza, etc. Absence of airflow obstruction means reduced FeV1 by FVC is present in both COPD and bronchiectasis, but quality of sputum. Sputum is clear in COPD. Sputum is very yellowish, purulence, and because it reflects the bacterial process. Let's try to understand the causes of bronchiectasis. For today's discussion and that for the exam, I want you to think of bronchiectasis as two different types. Two different types. Either it is cystic fibrosis, non-cystic fibrosis. Cystic fibrosis is a genetic condition, and I will tackle it separately today. The second kind of bronchiectasis is called as non-cystic fibrosis bronchiectasis. That can occur due to many causes. Some of them are highlighted in yellow on your slides. Multiple bacterial infection. The bacteria responsible for causing bronchiectasis, Mycobacterium avium intracellulare, MAI. Mycobacterium avium intracellulare, MAI. These are different bacteria than the TB bacteria that you generally we talk about, but it's very similar to that. Another fungal infection, Aspergillus. Don't come to the exam without knowing Aspergillus and MAI, because these are fair game. Infection of the airways with MAI, Mycobacterium avium intracellulare. Infection of the airways with Aspergillus. Both can result in bronchiectasis. Patients who have congenital deformities of the airways, there is a group of patients who have abnormal ciliary movement. I showed that slide in my fourth lecture, and I said it is primary ciliary dyskinesia. That was the reason I showed you there, to prepare you that abnormal ciliary movement of the airway lining can result in damage to the airways, and bronchiectasis occurs. Similarly, alpha-1 antitrypsin deficiency can also not only associated with COPD, but may be associated with bronchiectasis as well. Then there are patients with immunodeficiency. Those who have low IgG level, immunoglobulin G, the G immunoglobulin is the most common immunoglobulin which fights the infection. If it is not there, patient is at risk for developing repeated infections. Sometimes children who have repeated infections, bacterial infection in the childhood up to teenagers, they keep getting pneumonias, they keep getting bronchitis. It may leave some damage to the airways and cause bronchiectasis. Patients who have systemic disorders, something like collagen vascular disorders like rheumatoid arthritis, systemic lupus erythematosus, scleroderma, mixed connective tissue disorders are all at risk for developing collagen vascular bronchiectasis. Something interesting you should know, I talked about obstruction of the airways that can result in post-obstructive pneumonia. We also learned that it can cause unilateral wheezing. Repeated obstruction of one area in the lung can lead to damage to the airways in that area, and you can have localized bronchiectasis. These are some of the common causes of bronchiectasis you must know. How do these patients present? They present with shortness of breath, cough, sputum production. One thing in this you should know, patients with bronchiectasis usually come to the doctor's office with a jar of, they say, doctor, I produce this much of sputum every day. So they have very large amount of sputum production. This sputum is also has little putrid feeling because it's there and you get anaerobic bacteria. So these patients also have halitosis. Some of the worst halitosis that you would see in the hospital settings are those patients who have bronchiectasis. These patients also have fever, little bit of body aches, fatigue, etc., because of the bacterial process. I already mentioned that bronchiectasis is also associated with hemoptysis because all these patients have high inflammatory markers. These patients also are a little bit cachectic and they have clubbing. On an examination, you would see not only clubbing, but wheezing and crackles, wheezing and crackles. If bronchiectasis is bilateral, these are bilateral wheezing and crackles. If it is unilateral, you will see unilateral wheezing and crackles. So when should you suspect bronchiectasis? Patients who have chronic cough, more than 8 weeks, not getting better with the usual treatment, you will get a high resolution CAT scan. Patients who have repeated attacks of bronchitis leading to a large amount of yellowish sputum, think about bronchiectasis. Patients who are getting with recurrent pneumonia, think about bronchiectasis. Patient who has obstructive lung disease on spirometry, has shortness of breath, obstructive lung disease on spirometry, and has clubbing, think that patient has bronchiectasis. And the test of choice for diagnosis bronchiectasis is high resolution CAT scan of the chest. Simple. So just like asthma, just like COPD, bronchiectasis patients also get the exacerbation of their bronchiectasis. When there's exacerbation, there's more cough, more sputum, more shortness of breath, just like the COPD. The patients who get repeated exacerbations may benefit from Zithromax or azithromycin as an anti-inflammatory agent Monday, Wednesday, Friday for 1 year. Remember, I talked about this in COPD as well. We use this technique in treating patients with bronchiectasis as well if they continue to have like an exacerbation all the time. As I mentioned, I'm not going to ask a CAT scan on the exam. That's not the purpose here. As long as we know that CAT scan can diagnose bronchiectasis, and these are simple CAT scans which show dilatation of the airways, subtle findings here and some here, they can easily show that the dilatation of the airways is the finding hallmark for presence of bronchiectasis, and this is seen on high resolution CAT scan. The test of choice for bronchiectasis is high resolution CAT scan. As you can see on these CAT scans, we can see dilated airways, longitudinally dilated airways, sometimes smaller dilated airways. Nobody's asking CAT scan pictures on the exam, so please don't lose any mind on this. As long as we know the diagnosis of bronchiectasis is made on looking at the CAT scan and dilated airways, you're golden. That's what I want you to know. But here is the catch. Let's see how we work up bronchiectasis. It's rather simple. We have a patient with shortness of breath, cough, sputum production, not getting better, has obstructive lung defect. We do a CAT scan of the chest. And radiologists say presence of dilated airways with mucus, thick mucus lining the airways, suggestive of bronchiectasis. This is what I want you to do. Is it unilateral or is it bilateral? Is it unilateral or is it bilateral? If it is unilateral, the disease is localized to the lung. If it is bilateral, then the disease is a systemic disorder. So what are the unilateral processes? Same thing, foreign body, tumor, extrinsic compression of the airways from a mass, that area will have bronchiectasis. If it is bilateral, means diffuse, it's a systemic process. And let me take you through this. Is the dilatation in the center portion of the lung or the peripheral? When I say that, this is how it is. This area is the central portion of the lung. Can you guys see my cursor or not?
Yeah, we can see it.
Yes or no?
Yeah.
Yes.
Yeah.
Okay. So this is a CAT scan, and this area is the central part, where this is the peripheral part. Is bronchiectasis in the peripheral, central part of the lung, or is it in the peripheral part of the lung? That's important. So this is where we were. Bronchiectasis, is it unilateral? If it is unilateral, it's a unilateral cause. Either there is obstruction from tumor, extrinsic compression, mucus plug, foreign bodies, etc., etc. If it is bilateral on CAT scan, then it's a systemic disease. Is it in the central portion of the lung or is it in the peripheral portion of the lung? If it's in the central portion of the lung, for your level, it is from aspergillus. Keep that statement like gold. Get it into your brain right away. Central bronchiectasis seen on CAT scan is due to aspergillosis. The aspergillus fungus is involved. If the bronchiectasis is in the peripheral portion of the lung, you have to see, is it in the upper lobe, middle lobe, or lower lobe? If it's in the upper lobe, it's probably related to TB, cystic fibrosis, and some other causes. If it's upper lobe, it is TB or sarcoidosis or cystic fibrosis. If it's in the middle portion of the lung, and if it's in the middle portion of the lung, means middle lobe of the lung is involved, is due to Mycobacterium avium intracellular infection. Hold this statement with you. This is so important because MAI is commonly seen in this country and it involves the middle lobe of the lung on a CAT scan causing bronchiectasis there. And you can look at the CAT scan and be 100% sure that this patient has bronchiectasis. So if it is upper lobe, it is TB sarcoidosis. If it is central, it is aspergillosis. If it is middle lobe and the lingula on the left lobe, middle lobe on the right side, because middle lobe is in the right lung, and equivalent to that in the left lung is called as lingular lobe. Middle lobe or lingula is involved, that's MAI infection. If its lower lobes are involved, it is due to a post-infectious process, hypogammaglobulinemia, HIV infection, etc., etc. So you see, CAT scan not only diagnoses bronchiectasis, but also gives you a hint what is causing it. This slide is important. Patient with shortness of breath, obstructive lung disease, obstructive lung disease on spirometry. You do a CAT scan. Localized bronchiectasis is due to tumor, endobronchial obstruction, foreign bodies, extrinsic compression of the airways. If it is diffuse, means both the sides. If it is in the central portion of the lungs, it is aspergillus, aspergillus related. If it's in the periphery, look at the top apex of the lung. This is from cystic fibrosis, sarcoidosis, tuberculosis. If it's in the middle portion of the lung, it is MAI infection. If it's in the lower portion of the lung, it's either HIV infection, hypogammaglobulinemia, repeated infections from aspiration, etc., etc. So CAT scan not only tells you the confirmation of bronchiectasis, but also gives you an idea about the underlying etiology, what could have caused this. So some of my own patients, this patient has slight changes here, more subtle, but you can see bilateral, more on the right side and left side. This is from tuberculosis, bilateral upper lobes. What this patient, trust me, has this middle lobe, I'm saying central portion of the lung is more involved. This is from aspergillosis, and this condition is called as allergic bronchopulmonary aspergillosis. Allergic bronchopulmonary aspergillosis. ABPA. ABPA. These patients generally have mild crackles, severe history of wheezing. So a lot of time they're confused as asthma. Not only that, they have eosinophilia. All the more confusion to be confused with asthma. But these patients have antibodies to aspergillus in their blood. This condition is called as allergic bronchopulmonary aspergillosis. This type of bronchiectasis will be treated with not only steroids, but itraconazole, because you need to kill this fungus, otherwise patient's not getting better. So allergic bronchopulmonary aspergillosis, central bronchiectasis associated with eosinophilia, associated with IgE, generally confused with bronchial and asthma. But this is treated with steroids and itraconazole. Now you'll say, how can I diagnose it? A bronchial asthma patient who's not getting better on all the therapies that you've done, that we talked about. Give them steroids, give them LAMA, give them LABA, give them biologics. Patient's not getting better. You should think maybe this patient has allergic bronchopulmonary aspergillosis related bronchiectasis. These patients are treated with steroids and itraconazole. These are the other things that we see in ABPA, asthma, positive hypersensitivity skin test to aspergillus, elevated IgE, elevated immunoglobulin levels, eosinophilia, etc., in this group. Radiologically also, you see slight central parts of the lung has little dilatation. These are all of these, as you can see, some here, some there, some there, some this area, a little bit. So it can be very subtle to very obvious. What about the non-tubercular mycobacteria or Mycobacterium avium intracellularly? Mycobacterium avium intracellularly has two types of disease. It can cause nodules in the lung, or it can cause bronchiectasis in the lung. When it is bronchiectasis in the right middle lobe or the lingular lobe, this type of mycobacteria is not contagious, people. Mycobacterium avium intracellularly, also called as Mycobacterium avium complex. You cannot transfer from one person to the other. So please, you're okay with that. But MAI is commonly diagnosed in this country, and it may be related to bronchiectasis. And these are some of my patients who have middle lobe and lingular involvement, and very subtle lingular involvement. The treatment of MAI, Mycobacterium and Mycobacterium intracellularly, they are very similar species. Put them together and we call that as Mycobacterium avium complex. MAC complex comprises two very similar non-tubercular mycobacteria, Mycobacterium avium intracellularly and Mycobacterium avium itself. The treatment of this kind of bronchiectasis requires sometimes 4 antibiotics and 2-year treatment. 4 antibiotics and 2-year treatment. It's a torture for the patient. Treatment is based on clarithromycin, ethambutol, rifabutin. And another antibiotics can be ciprofloxacin and things like that. Please keep it in mind, something, wake up now, this is what I want you to remember. MAI is not treated with INH, which is INH is only reserved for TB. MAI is not treated with INH, but similar other drugs, clarithromycin, rifabutin, and ethambutol and ciprofloxacin or some other antibiotics are used to treat that. The treatment goes on for 2 years, and you need to show negative sputum cultures for you to stop it. So it's a prolonged course. It's not a 6 months, 3 months, 9-month treatment. MAC treatment goes on for more than 2 years. You can sometimes have, not only a weekly treatment, but twice weekly or thrice weekly treatment. That's outside the scope of our lecture today. But the point is well taken. MAI infection in the lung causes middle lobe and lingular lobe bronchiectasis, and it is treated with rifampicin and ethambutol-based therapy with some other antibiotics for 2 years period. It's a little bit difficult challenge for patients to take. Okay. NTM lung disease, we talked about. Patients with primary ciliary dyskinesia. I hope you remember this slide also was shown in lecture number 4. These patients have nasal polyps, dextrocardia, heart is on the left side instead of being the right side, and they have bronchiectasis. So triad of nasal polyps, dextrocardia, and bronchiectasis tells you about primary ciliary dyskinesia. This condition also called as Cartagener's syndrome. These patients, this is an autosomal recessive disorder, but you do see once in a while. So bronchiectasis with nasal polyp, there are a few choices. You can see it in cystic fibrosis. You can see it in allergic bronchopulmonary aspergillosis, but you also have to rule out primary ciliary dyskinesia. Okay. So if we know this, what is the workup of a patient after you have looked at the CAT scan? What you're going to do? We do some blood tests, some of which tells us what caused it. You'll do CBC, immune globulin levels, you do spirometry, obviously high resolution CAT scan is done. We also measured alpha-1 antitrypsin level, we measured antibodies for collagen vascular disorder. Something very important we do in bronchiectasis, which I did not say it in COPD, I did not say in asthma, is that we send sputum for culture. We send sputum for culture. I never mentioned that in COPD or asthma. Some patients may even require ciliary, nasal, or lung biopsy to look at the cilia. We also do something called a sweat chloride test, which is abnormal in cystic fibrosis. I'll talk about that in a minute. So the workup for bronchiectasis is a little bit more involved as compared to asthma and COPD. So here it is. Suspect bronchiectasis, get a chest X-ray, high-resolution CAT scan, spirometry, sputum cultures, and look for WBC count, IgA, IgM, IgG levels, alpha-1 antitrypsin level, immunoglobulin levels, antinuclear antibodies, etc., etc. If everything is negative, you want to rule out cystic fibrosis by doing sweat chloride test. If the patient is not able to produce sputum and you have not come up with any answer, you may want to do bronchoscopy and biopsy of the airways to rule out primary ciliary dyskinesia, to look at ciliary function. You also will look at the nasal nitric oxide levels, which are decreased in patients with ciliary dyskinesia. Patients with cystic fibrosis and patients with non-cystic fibrosis have very high sputum burden. They need to cough out sputum all the time. So we use certain techniques to help them bring out sputum. I didn't mention this in COPD or in asthma. Exercise will help you do that. Hypertonic saline, 7% saline is nebulized, is given to these patients, so that sometimes liquefies the sputum which is stuck in the airway so they can cough it out. Sometimes we do some positive expiratory pressure devices which causes vibration of the chest so that patient can cough it out. So some other techniques are used for these patients. Okay. I have taken you through this. This tells you a little bit more about the treatment aspect of this. Bronchiectasis, you have confirmed it on the CAT scan. It is not unilateral, but it is bilateral. If patient has a known underlying cause, they have immune globulin deficiency, alpha-1 antitrypsin deficiency, then those should be replaced. Patient should be started immediately on airway clearing devices, which is 7% saline nebulization, chest physiotherapy, etc., etc. Nowadays, there is a new drug available. Don't come to the exam without knowing it. Its name is brensocatib. Brensocatib. That drug sometimes helps with liquefaction of the sputum and help you cough the sputum out. Brensocatib. Didn't mention that for COPD or asthma. We rely very heavily on sputum culture. If sputum culture is normal, you observe. If sputum culture shows non-pseudomonas bacteria, you treat it with an antibiotic. If patient has pseudomonas, and I want you to remember, even if you don't want to remember anything, you must know pseudomonas has specific predilection for bronchiectasis. Once it's in the lung, it is very hard to eradicate pseudomonas. So we give these patients may be given inhaled antibiotics or Zithromax light of treatment for a prolonged period of time if it is Pseudomonas in the sputum. If the sputum shows non-tubercular mycobacteria, you will give the 4 drug treatments, etc. I talked about. I am not asking which regimen to treat with for non-tubercular mycobacteria, as long as we know it requires prolonged courses of antibiotic. And also brensocatib is the drug which helps in airway clearance. A few words about the role of antibiotics. Antibiotics have a role in non-Pseudomonas bacteria, but in Pseudomonas bacteria, you will give them penicillin-based therapy to eradicate the Pseudomonas, or you will give inhaled antibiotics or Zithromax to suppress the Pseudomonas. Okay. As you see, we give these patients, if patient has Pseudomonas, you can give them long-term macrolides, which is Zithromax 3 times a week. We do give these patients inhaled steroids, but we are not very big on this. It's not the first drug of choice in bronchiectasis because inhaled steroids sometimes can cause pneumonia. Remember what I talked about COPD yesterday? So inhaled steroids have a very little role in bronchiectasis, big role in asthma, minor role in COPD, very minimal role in patients with bronchiectasis. We do use brensocatib. It is a medicine to be used. It helps in decreasing the inflammation of the lung, liquefaction of the sputum, and patients feel better. So the antibiotic therapy, during first line, you would use ampicillin, etc. For long-term use in patients with Pseudomonas, you would use either inhaled antibiotics or oral Zithromax 3 times a week. Still confused about it? Here it is. If patients having repeated exacerbation of bronchiectasis, if the sputum culture shows non-Pseudomonas culture, you can put them on long-term macrolide therapy and go from there. If it shows Pseudomonas in the sputum, you have 2 choices. You can give inhaled tobramycin, inhaled colistin, etc. for a long period of time. So just to keep you at ease, I'm not asking what antibiotic. As long as you know the inhaled antibiotics are specifically kept for Pseudomonas. Zithromax can be used for Pseudomonas or a non-Pseudomonas infection to suppress the inflammation in the airways. What are the complications? Please remember, bronchiectasis can lead to pneumonia, lung abscess, pleural effusion, massive hemoptysis, right heart failure. Bronchiectasis is also associated with brain abscesses, repeated infections. You can get the bloodstream blood and seeded in the brain. We see less and less common of this complication, but countries where the antibiotic availability is poor, they still get brain abscesses. And lastly, long-standing bronchiectasis can predispose to amyloidosis. Let's move on to cystic fibrosis. Now, remember in my lecture initially, I said we're going to divide bronchiectasis into cystic fibrosis related bronchiectasis, non-cystic fibrosis related bronchiectasis. So let's briefly look at cystic fibrosis as well. Now, cystic fibrosis is a genetic condition. It's a genetic condition. It's also due to abnormality in the long arm of chromosome 7. Long arm of chromosome 7. The gene that is defective in long arm of chromosome 7 is called as cystic fibrosis transmembrane conductance regulator. It's a tongue twister. The gene defective in cystic fibrosis is called as CFTR gene, CFTR gene. This gene is responsible for chloride channels in the cells. All our cells have a chloride surface, have a chloride channel so that chloride can move in and out of the cell. That function is controlled by the CFTR gene. And if the CFTR gene is defective, your chloride is not going inside the cell or moving outside the cell easily. It's the chloride channel problem. That's in short, what is the problem with cystic fibrosis? They have abnormality in the chloride channels of their cell. Okay. So if the CFTR gene is affected and not doing its job, in many ways, problems can occur. So the mRNA, which is produced by the endoplasmic reticulum, it's not able to move stuff into the nuclei. And even it is affecting in many ways the activity of the chloride channel, which is present at the surface of the cell. By the way, this CFTR abnormality affects any exocrine gland, your sweat gland, your pancreas, your lungs, glands in the lungs, your sweat glands, those kind of things, not endocrine organs. Okay. So let's just learn a little bit about what is the problem with the CFTR gene. The CFTR gene, the green one, codes for chloride channel so that chloride can go in and out of the cell properly. Wherever the chloride will go to maintain electrical neutrality, sodium will travel, but through another channel, not through this channel, but another channel. So sodium mobility is not a problem. It is the chloride mobility is the problem. Water can go up and down depending upon where the sodium chloride is moving. So in patients with cystic fibrosis, the sweat glands, the chloride cannot move out. Once the sweat is formed, the chloride from this cannot move out. So when it comes out, it has high chloride level. That is the way of diagnosing cystic fibrosis. Elevated sweat chloride. The chloride channel of the sweat glands are not functioning. Otherwise, generally, when the sweat is formed, as sweat is moved through the duct, the chloride moves out and you have an isotonic sweat. But in this case, the sodium is not able to move out and you have a sweat which has a very high level of sodium. So have a high level of chloride. Sweat chloride elevation is the way to diagnose cystic fibrosis. So normal CFTR channel, the chloride will come and will move inside the cell because another channel, the sodium will move in the channel. So they result in have healthy layer at the above and inside the cell. Sodium in or sodium out moving, a chloride movement is not a problem. In patient with cystic fibrosis, chloride channel is not working. So what happens, the chloride is trapped inside the cell. Because chloride is trapped, so sodium moves on inside to neutralize this chloride. It causes dehydration of the mucus that is present on the cell. When mucus is dehydrated, the cilia cannot do their job. Now this mucus is now jelly-like. It gets infected. Repeated infections cause bronchiectasis. CFTR mutation, abnormal CFTR proteins, abnormal salt and water transport, dehydrated sputum. I showed you how the dehydrated sputum occurs. Chloride channel is not allowing chloride to go out, so the sodium from the mucus moves in. mucus becomes very defective, is dehydrated. The dehydrated mucus leads to airway obstruction, infection, inflammation, enzymatic DNA of the bacteria, and this process continues, further destruction of the airways, and these children develop respiratory distress. Okay. Diagnosis of CFTR in adults, cystic fibrosis in adults. We now diagnose it sometimes in adults as well. Generally, this condition is diagnosed much early in life. This is a disease generally picked up when the child is around 2, 3, 4 years of age, because they're getting repeated lung infections, failure to grow, etc., etc. So the diagnostic criteria is to have sweat chlorides. Sweat is collected and your chloride is measured more than 60 millimoles per liter, is very suggestive of diagnosis of cystic fibrosis. We can also measure cystic fibrosis, CFTR gene mutations as well, which can easily be done nowadays. I want you to know that cystic fibrosis is a systemic disorder. Systemic disorder. It affects the pancreas, it affects the sweat glands, it affects the skin, it affects the liver, it affects even the GI tract as well. It affects the vas deferens. Patients can have obstructive azoospermia, etc., etc. In this country, there is a newborn screening done. In the newborn screening means the cord blood is taken and you measure for immunoreactive trypsinogen. Remember, trypsinogen is an enzyme made by the pancreas. If the pancreas duct is not functioning, the trypsinogen spills into the blood. So if immunoreactive trypsinogen is elevated in the cord blood, that is first sign that the child has cystic fibrosis. Then you can do the elevated sweat chloride test. You can measure genetics as well to look for CFTR mutations, etc., etc. So why are we discussing it? Because this structure leads to dehydration of the mucus in the airways, repeated infection, Pseudomonas and staph infection, and ultimately bronchiectasis and destruction. This is how a normal lung looks like at birth. Repeated infection and inflammation causes holes in the lung, more in upper lobe and as compared to lower lobes. This is a CAT scan, which shows all this dilatation. This is how the autopsy specimen looks like. The normal looking lung is now riddled with all kind of bacterial processes leading to respiratory failure. The bacteria that causes problem in this age group in cystic fibrosis are not only Pseudomonas, but also staph, in addition with some other bacteria as well. So staph and Pseudomonas infections in the lungs are important in patients with cystic fibrosis. Management, we need to rehydrate the mucus. We need to help clear out the mucus. We need to give antibiotics and a whole lot of other things. So first thing we do is we give them an airway clearance device. As I talked about, airway clearance devices are those which help you bring out the sputum. There are many of these devices, from a flutter valve, where basically there's a tube which has a flutter valve and you breathe in and out in this. It causes flutter. So it causes flutter in the airway, so that helps the sputum out. There's another thing in which you measure a vest, like a shirt. It vibrates the chest and patient is able to cough out. So the airway clearing devices have a very special role in bronchiectasis. I did not say that for asthma or bronchiectasis. In addition, what else can we do in non-cystic fibrosis bronchiectasis? We gave them 7% saline to liquefy the sputum. In cystic fibrosis, we give them recombinant DNase. Recombinant DNase, also called as Dornase alpha. Recombinant DNase liquefies the sputum in the airways and helps the patient cough it out. Now, recombinant DNase is very specific to cystic fibrosis, and we use it very effectively in our 8 patients. Sometimes we will use azithromycin as 3 times a week, just as an anti-inflammatory agent. I also want you to know We are in 2026. The genetic revolution has started. Now, in some patients with cystic fibrosis, we can give them specific medications which can go inside the cell and fix the abnormality. Just to wake you up a little bit, I showed you that the abnormality of the CFTR gene can be many different types. It can have abnormal protein not being formed in the cell, in the nucleus, or it's not being brought out from the nucleus into the cytoplasm, or it does not reaching the periphery of the cell, or even if it is reaching, it's not doing its job properly. Some of these genetic defects can be fixed by medicines called as CFTR modulators. I have a whole bunch of extra slides in there. That's not what I want for you guys. All I want is CFTR modulators. These target and force the cell to produce different kind of proteins which can then fix the chloride channel. Yes, this is happening right now. And that is why the prognosis of cystic fibrosis has improved. 30 years ago, when I started, the prognosis was not as good. Today, patients with cystic fibrosis are living into 40, 50, 60s, and 70s because we have these specific medications which can fix the genetic defect. So in cystic fibrosis, it's not just inhaled steroids. No, it is liquefaction of the sputum by giving Dornase alpha, giving chest physiotherapy and airway clearing devices, antibiotics, inhaled, oral, or long-term to do this. And if possible, treat the underlying cause. If it is MAI, you treat MAI. If it is aspergillus, you say aspergillus. If it is IgG deficiency, you treat immunoglobulins. If it is alpha-1 antitrypsin, you do that. If it is associated connective tissue disorder, you treat the underlying condition as well. So there are different kinds of medications, lumofactor, tasacaftor, ivacaftor. No need to remember these medicines. This is for you to wake up and appreciate where the field has gone. From simple damage to the airways to the point that we can now have medicines which can go inside the cell and fix a genetic defect is pretty incredible. In your lifetime, people, cystic fibrosis will be a curable condition. Already we have made so much advancement. People are living longer and having a good quality of life. But I believe in next 20 years, we'll have more of these CFTR modulators, which will go inside the cell and fix the genetic defect so that the gene can do its job, secrete the protein that needs to act on the chloride channel to do its job. Okay. There are many types of antibiotics. I've kind of given you my spiel on this already. We inhaled steroids have very little role because these are, it sometimes can cause more inflammation. Sometimes we use brufen as well. Oral Zithromax as an anti-inflammatory agent, we do that. So I put this together here. What is the treatment? CFTR mutation, we are doing gene therapy, CFTR modulators. Abnormal salt and water transport, we give the patient Dornase alpha, hypertonic saline, etc., to help with liquefaction of the sputum. Sometimes we get bronchodilators to dilate the airways, in antibiotics to suppress the infection, hypertonic saline, recombinant DNase, chest physiotherapy, pulmonary rehab to help with the sputum production, its liquefaction, and its expulsion. All patients with cystic fibrosis are also listed for lung transplant. Because if this doesn't work, patient can be listed for lung transplant. What is an advanced cystic fibrosis patient whose FEV1 is less than 40? If it is less than 40% predicted FEV1, you should refer them for lung transplant. Refer them to lung transplant. Patients who have elevated CO2, patients who have been to ICU multiple times, patients who have pulmonary hypertension, patients who have very limited mobility are all at risk for a respiratory failure and will have a shortened quality of life. Needless to know, more exacerbations, decline in the lung functions, more infections, massive hemoptysis are all poor prognostic signs in patients with cystic fibrosis. Just to inform you, we do very big pancreatic replacement, pancreatic enzyme replacement in cystic fibrosis patient. This is only for cystic fibrosis. Please don't consider it for non-cystic fibrosis, bronchiectasis, or asthma for COPD. Because cystic fibrosis patients have pancreatic insufficiency. They don't produce trypsin, amylase, lipase, those kind of enzymes. So we replace pancreatic enzymes in this patient. We give them the fat-soluble vitamins also have to be replaced. Vitamin A, vitamin D, vitamin E, and vitamin K are replaced in these patients. These patients have a high incidence of osteoporosis. They have a high incidence of diabetes, etc., etc. So I've taken you through a journey of 3 different kinds of airway disorders. We talked about asthma, role of reversibility, role of eosinophil, role of steroids. We talked about COPD, noxious stimuli, progressive in nature, anti-alpha-1 antitrypsin, smoking related. Then LAMA was the drug of choice. Then you add LAMA to LAMA. Then you add LABA to LAMA, LAMA, LABA. Then you either add inhaled steroids, but you also had the choice to add ensifentrine. You had the choice to add roflumilast. You had the choice to add Zithromax. You have a choice to add Duplimab. All those treatments. Wherein cystic bronchiectasis, we divided into non-cystic fibrosis and cystic fibrosis, 2 different kinds of bronchiectasis. We learned the causes of non-cystic fibrosis bronchiectasis. The treatment is to treat the underlying cause, whether it's MAI, aspergillus, sarcoidosis, cystic fibrosis, hypogammaglobulinemia, and then we give them bronchodilators and also a 7% saline in non-cystic fibrosis bronchiectasis to liquefy the lungs. In cystic fibrosis 1, in addition to normal saline, we use Dornase alpha, which liquefies the sputum of cystic fibrosis patients. And we also used CFTR modulators, specific therapies to fix the genetic defect. We also, in cystic fibrosis, because it's a systemic disorder, we give them vitamin A, vitamin D, vitamin E, vitamin K, pancreatic enzymes, systemic treatment, fix the diabetes, fix osteoporosis. At the end of the day, all bronchiectasis patients should be listed for lung transplant because if they don't do well, they need to be on the transplant list. I hope we have given you a good overview of bronchiectasis from clinical and exam point of view. If you have understood this, if you retain only half of what I talk, I think we will be fine. Any questions about bronchiectasis at this point of time, people? Either ask or you put it in the chat. As usual, when there's no question, I get worried whether these people are actually listening to me or they're playing games and just have the lecture on. I have no idea how to monitor.
We're listening.
Yes. What's the question? I don't know who asked the question, but okay, we are listening. Thanks. Okay, people. Let me, do you have the next slide? That next slide says neoplasm, lungs cancer. Do you have those slides or not? Or do I need to send it? It's 5:26. I will start at 5:31. Take a 5 minutes break and we start the next lecture. I'm going to stop sharing my screen at this point of time. We need new. Okay, can you see my slides, please?
Yes, we could see your slides.
So I'm told that the last lecture, the slides were different than the ones that you had. Did
There's
that happen?
usually 1 to 2 slide differences.
Okay, not much, right? I don't think there was, but anyway, I'll send this one to Karen soon and make sure that you guys get it. Okay, let's talk about lung cancer for a minute. Now, lung cancer violates my rule that it can also involve the airways, it can involve the alveoli, it can involve the interstitium, it can involve the pleura, it can involve the chest wall. So lung cancer and the lesions, benign and malignant lesions of the lung can go anywhere. But one thing is clear. Most of the malignant processes of the lung originate in the airways. One more time. Most of the malignant processes of the lung, primary lung malignant processes of the lung, originate in the airways. Now, lung cancer incidence has declined. It is declining both in males as well as in females as well. The incidence and the mortality, both in the male and female, have declined. It is because I think there's consistent effort on parts of the public health officials in alerting people about the role of cigarette smoking, which seems to be the biggest risk factor for lung cancer. So hopefully we'll continue to see these declines in this. For today's discussion, I want you to think of lung cancer, two main types. Non-small cell cancer, small cell cancer. Non-small cell cancer is more common, 85%. Small cell cancer, 15%. But small cell cancer has the worst prognosis. Small cell cancer has the worst prognosis. The non-small cell cancer can be subdivided into squamous cell, adenocarcinoma, and others. Squamous cell, adenocarcinoma, large cell carcinoma, and others, very different kinds. Of all these, people just wake up, and I'll ask you in the exam, the commonest lung cancer today is adenocarcinoma. The commonest lung cancer type of lung cancer today is adenocarcinoma. One more time, small cell cancer, only 15% has the worst prognosis. Non-small cell cancer, 85%, divided into squamous, adeno, large cell, and others. Of these, put together all the cancers, adenocarcinoma is the most common cancer in the lung. What are the risk factors? It goes with smoking. Current smoking, 20 times. Relative risk is 20 times. Former smoking, 9 times. Secondhand smoke exposure, 1.3. In addition, exposure to asbestos. Asbestos is not going to leave you because it causes lung cancer, it causes mesothelioma, it causes pleural plaques, it causes interstitial lung disease, many different things that it causes. Exposure to asbestos and radon also predisposes a person to lung cancer. Two other lung causes of lung cancer that you must know. One is HIV infection. HIV virus likes to live in the lung. It causes pneumonia, it causes COPD, and it also, to some extent, leads to lung cancer. Please know this. Patients with pulmonary fibrosis are at high risk for lung cancer. So are patients with COPD. We talked about that yesterday. Patients who have history of radiation to the chest, people who have Hodgkin's lymphoma in during the childhood, you generally are treated with radiation to the chest. And we have seen that some of them will develop lung cancer 30, 40 years later. History of radiation to the chest is important because it is associated with the secondary incidence of lung cancer 30, 40 years down the line. Being on chemotherapy for any cause predisposes you for another second malignancy, which generally is lung cancer. Please note, people, family history of lung cancer is important. The presence of family history predisposes persons to develop lung cancer as well. Squamous cell carcinoma. Squamous cell carcinoma is a type of non-small cell cancer. It is related to smoking. It occurs in males more commonly, and it is a central tumor. Means this is the trachea, this is the bronchus. It occurs in the central part of the lung. Non-small cell cancer people metastasizes to 4 areas: bone, brain, adrenal, bone, brain, adrenal, and liver. Bone, brain, adrenal, and liver through lymph nodes. So it has a lymphatic spread. Same for adenocarcinoma. They go to bone, brain, liver, and adrenal through the lymphatics. And this, because it may be an upper lobe tumor, it can infiltrate the cervical ganglion, etc., also. Adenocarcinoma, on the other hand, because it's a peripheral tumor. One of my patients has a small lesion like this. One of my patients has a squamous cell cancer. You can see that. The adenocarcinoma is a peripheral tumor. When it is peripheral tumor, it may remain silent for a long period of time and doesn't come to attention. Again, it has lymphatic spread. It goes to the bone, brain, liver, and adrenal, BBLA as I call it, and can spread there. Squamous cell is more common in males. Adenocarcinoma is more common in females. Both are related to smoking. But I do want to point out that the incidence of adenocarcinoma in women who are non-smokers has increased. One more time, the incidence of adenocarcinoma in women who are not smoker has increased. Let me paraphrase it one more time. Incidence of adenocarcinoma in non-smoking South Asian descent females has increased. It has to do something with genetics, as we will talk about. In addition to these two types of non-small cell cancer, which originate in the airways, squamous cell in the major airways, peripheral, central airways, adenocarcinoma in the peripheral airways. Third kind of cancer, which is non-small cell, is called as bronchoalveolar carcinoma. Bronchoalveolar carcinoma. This arises from the alveolar lining. This arises from the alveolar lining. In this case, the alveoli, which are the normal ones, are these single-line cells, now have multiple mitotic cells lining the alveoli. If you shoot a chest X-ray, you will look like an alveolar filling defect. You will have a bronchogram, things like that. That's why bronchoalveolar carcinoma can mimic a pneumonia. So here's the dictum. Pneumonia, after proper treatment at 6 weeks, we always do a chest X-ray to look for a resolution of the radiological opacities. If you're a patient you diagnose with pneumonia, you treat them with antibiotics, and at 6 weeks, 8 weeks period, it hasn't changed at all, you must think of bronchoalveolar carcinoma. It's a differential diagnosis of non-resolving pneumonia. It's a differential diagnosis of non-resolving pneumonia. It's of very different kinds. It's subdivided into many different kinds. That is probably not necessary for this class. Adenocarcinoma in situ, minimally invasive adenocarcinoma, lipidic predominant adenocarcinoma, and invasive mucinous adenocarcinoma. I put it on the slide because when I don't put it, so always one student will send me an email saying, hey, you didn't talk about the subdivisions of bronchoalveolar carcinoma. So I put it up there, but no need for you to remember it. What is more important for you to remember? Bronchoalveolar carcinoma may not be associated with smoking. It is, of all the cancer, it's the least associated with smoking. It is least associated with smoking. I talked about the genetics of lung cancer. Nowadays, we believe there are certain mutations in the genetic material, which predisposes people to develop malignancy. One of them is EGFR, epidermal growth factor receptor mutations. These mutations code for non-small cell carcinomas, particularly non-small cell carcinoma leading to adenocarcinoma type in people with Asian descent, particularly women with Asian descent. So EGFR mutations are causing the cancer, which is not related to smoking in the woman that I talked about. There are some other mutations, ALK mutation, KRAS, BRAF, and many other mutations. Why am I talking about it? Because nowadays when we take a biopsy, send it for examination, the pathologist actually sends part of the tissue for genetic analysis, and they tell us what genetic mutations are there. It is another type of pharmacogenomics, because based on this genetic mutations, we can tailor-made the therapy for our patients. How interesting is that? The lung cancer treatment has moved into not only looking at the slide from pathology, but also genetic mutation analysis as well. Based on these mutations, we give them chemotherapeutic agents as necessary. That's very specific for adenocarcinoma at this point of time. As I told you, single driver mutations in non-small cell carcinoma, particularly adenocarcinoma type, EGFR, ALK, KRAS mutations are there. These mutations are measured on biopsy and informed to the clinician. Clinician will give specific chemotherapy based on these mutations. Large cell carcinoma is also a type of adenocarcinoma. This one grows slowly. Its metastatic disease to BBLA, brain, bone, lung, and liver and adrenal, is a little slow. Okay. So a little better prognosis. What about small cell carcinoma? Small cell carcinoma is 15% of all the lung cancers, but it is very aggressive. It does not go through the lymphatics, it spreads through the blood vessels. So it has a hematogenous spread. In fact, by the time it's diagnosed, most of the time, it's already spread to the brain. So small cell cancer, by the time it comes to our attention, generally is outside the lung. That's why it has such poor prognosis. Small cell cancer has some other interesting features. It acts like a paraneoplastic syndrome. What is paraneoplastic syndrome? A lot of small cell cancer cells acquire capability of producing various kind of hormones. For example, it can secrete ACTH. Patient will have Cushing syndrome. It can secrete antidiuretic hormone, which is ADH. Patient will have hyponatremia. Sometimes it secretes antibodies, which can block the neuromuscular, the muscles. Patient can have weakness and myasthenia gravis type picture. This condition is called as Eaton-Lambert syndrome. So small cell cancer may present as a lung mass. It may present as brain lesion. It may present with its first presentation may be a primary endocrine problem. Very interesting, and that's why it is sometimes difficult to diagnose this condition. So if a patient has hyponatremia and a lung mass, it's generally a small cell cancer. If patient has Cushing's features, hypokalemia, elevated ACTH, chances are patient has small cell cancer. So how does lung cancer present to the clinician? It has 4 different types of presentation. Let's go through each one of them. One is local symptoms, when the tumor is pressing and irritating the adjacent areas. It can cause cough, it can cause shortness of breath, it can cause hemoptysis, rarely chest pain as well. Sometimes patients may have clubbing or osteoarthropathy. I'm not going to go into the details of clubbing, which probably people already know, which is the obliteration of the angle of the nail with the nail bed. So presence of clubbing is a very important features in patients with lung cancer. If patient has a lung mass and clubbing, the lung mass is malignant, not benign. Okay. Local presentation. Second, symptoms secondary to regional metastasis. Tumor irritating the esophagus will cause dysphagia. Tumor irritating the recurrent laryngeal nerve will cause hoarseness. Tumor irritating the pericardium will cause pericardial effusion. Tumor irritating the vessels will compress the superior vena cava in the chest and cause superior vena cava syndrome and things like that. For example, some of my patients, this patient has a tumor at the apex of the lung, so it is actually affecting this superior cervical ganglion. These patients will have ptosis, meiosis, and loss of senior spinal reflex. But you can see the meiosis on the left side in this patient. Similarly, sometimes if tumor is pressing on the SVC, which is in the upper part of the lung, patients will have a puffy face. They may open up collateral vessels on the chest wall as well. As you can see, this patient also have gynecomastia. This is because this tumor was secreting beta-HCG. So it can be local symptoms, it can be adjacent area symptoms, then it can be metastatic symptoms, symptoms far away from the lung. Liver metastasis will cause abnormal hepatomegaly. Bone metastasis will cause bone pain. Brain metastasis will cause headache. Adrenal metastasis can cause adrenal insufficiency. The fourth presentation is just paraneoplastic presentation. The tumor is silent. Our patient does not have lung features, no shortness of breath, no cough, but patient starts developing Cushing syndrome. Patient has persistent low sodium due to syndrome of inappropriate ADH secretion. So lung cancer is presentations very different. Local symptom, adjacent symptoms, metastatic symptoms, and paraneoplastic syndrome, 4 types. Of the paraneoplastic syndrome, small cell can secrete ACTH, it can secrete ADH, it secretes antibodies to cause myasthenia gravis syndrome, which is called as Eaton-Lambert syndrome. Squamous cell, on the other hand, is associated with hypercalcemia because it secretes PTH-like hormones. Large cell cancer secretes gonadotropins, and it is associated with gynecomastia, as was in the previous slides. Neuromuscular weakness occurs from small cell cancer because they secrete antibodies which can block the neuromuscular junctions. I mentioned this neuromuscular junction problem in my lecture number 2 when I talked about hypercarbia as well, if people were awake at that point. How do we diagnose lung cancer? The common instinct is to say chest X-ray, but chest X-ray will not pick up lesions which are less than 1 centimeter or they are behind the pericardium or heart. Chest X-ray can miss a lot of early lesions. The test of choice for you is CAT scan of the chest. CAT scan of the chest. CAT scan of the chest tells you anatomical location, but we need to have a tissue diagnosis because treatment is based on what kind of cancer patients have. And is it really cancer or is it a benign nodule? So we need to do a biopsy. So chest X-ray, not that helpful. Biopsy to establish the type of cancer. Chest X-ray to look for localized lesions and some other things as well. This is how I want you to think of them. Sputum cytology is least invasive, but generally not helpful. You can do bronchoscopy if you go inside the lung and take a biopsy. You can do transthoracic needle biopsy. You go from the side and take a needle, or you can do an open lung biopsy. Least invasive to most invasive. Most invasive will give you the definite answer, but it is very invasive. One of the techniques that we use in our patients with lung cancer suspected, we'll do a PET scan, positron emission tomography. In this condition, fluorodeoxyglucose labeled RBCs are injected in the patient's antecubital vein. Now, fluorodeoxyglucose. As soon as these cells go into the lung, malignant cells take glucose much more faster than the non-malignant cells. So fluorodeoxyglucose is taken up. Fluorodeoxyglucose is taken up by the cancer cells, and when we shoot the camera, these cells, this areas light up. So PET scan can show us exactly where the tumor is, even if we are not sure. If there are multiple lesions, we do PET scan. The one which lights up the most is the one that we like to biopsy. So PET scan can give us an idea as to where and which is the most active area of the tumor. Patients who have benign lesions, their PET scans are silent. Patients who are malignant lesions, their PET scans show this problem. Particularly in patients who have solitary pulmonary nodule or a small nodule in the lung, whether to go after it and biopsy it or not. If PET scan shows it picks up, we have to remove it because that means a high chance of cancer. If not, then you can wait. So PET scan does give you an idea. And what do we look on PET scan? Something called as standard uptake value, SUV. SUV of more than 2.5 generally suggests a malignant process. PET scan be false positive in sarcoidosis and cryptococcosis lesions can be rarely be false positive, just to let you know. Can it be false negative in patients with carcinoid of the lung? And it comes in the exam. Carcinoid of the lung is a very slow growing tumor. It does not take much glucose. So PET scan is false negative. PET scan is false negative in carcinoid, in bronchoalveolar carcinoma, and some other neuroendocrine tumors. These are the common mutations. I've already sensitized to it. EGFR, BRAF, ALK, MET. Do I want you to remember this? No. But I want you to appreciate that nowadays when we send a tissue to the pathologist, they're not only confirming the presence of cancer, but they're also sending genetic material, pathology material for genetic testing, so that we get a report as to what are the mutations present in the cancer cell, and chemotherapy is based on that. It's called as pharmacogenomics, and it helps us target the cancer cells more effectively. So these are the ones that we do. And something else that is measured is PDL1, programmed cell death protein 1. These levels are also measured in the cancer cells. PDL1 measurements are also done. No need to sleep over this. I'm not asking what is being monitored on this, but this I'm giving you a flavor of what the oncologists do at this point of time. They just don't rely on pathology. They rely on what are the mutations are present in the cancer cells. And we also measure something called as PDL1 for all non-small cell cancer. It tells us whether it is high or not. If this is high, it may respond to a different kind of cancer. If these levels are low, these are the markers on the cancer cells. If they are low, they respond differently to different kind of chemotherapy. So a lot of things go into today in pathological diagnosis, not only just whether it's squamous or adeno. We look at the genetic material, we look at the PDL1 testing as well. How do we stage lung cancer? Lung cancer is staged in non-small cell cancer is staged in stage 1, 2, 3, 4. Let's go through this together so that it's easy. Non-small cell cancer is either limited or extensive. Limited means limited to the lung, which is 15 to 20% of the time, but extensive means it is all over the body. Whereas non-small cell, 1, 2, 3, 4. Stage 1. Lung cancer is present in one lobe of the lung. It can easily be removed. Stage 1, cancer is only one lobe of the lung. It can be removed. Surgery is the treatment. Stage 2, lung cancer is present in one lobe of the lung and also the lymph nodes which are present inside the lung. Surgeons can go and remove all of it and there is curative treatment. So stage 2, treatment is surgery. So non-small cell, stage 1 surgery, stage 2 surgery. Stage 3, lung cancer is present in the lung, lymph nodes in the lung, and lymph nodes in the mediastinum. We divide it into stage 3 and 3B. That's not important. This one may or may not be treated by surgery alone. Sometimes we give chemotherapy, etc., etc. So that becomes a bigger ball game. Stage 1 and 2 surgery, stage 3 and 4 chemo and follow-up, and chemo, radiation, etc. Stage 1 and 2 surgery, stage 3 and 4 chemo, radiation, and follow-up, etc., etc. We talked about stage 3. Stage 4 can be anywhere. Obviously, surgery is not possible. It's in the brain, bone, liver, adrenal, and what have you. Small cell cancer, divided into limited stage when it is only present in the lung, extensive stage when it is present outside the lung. Most of the small cell cancer that we see is extensive stage. Less than 15% of the time, it is in the lung itself. So most of the small cell cancer surgery is out because it's extensive. It's already in the brain, bone, liver, adrenal, etc. So by far for you, the treatment of small cell cancer is chemotherapy, plus minus radiation. Just to recap, there is a TNM classification of the tumors as well. We look at the size of the tumor, the lymph nodes involved, etc., etc. This is just for you to remind you, we do go through a TNM classification. It's very extensive. It's not for this group to remember this. And this classification is evolving as I was speaking around, and version 10 is already out. So this is for the oncologist and radiation therapy to look at the specific lymph node levels that are in. To recap, treatments, what are the 4 options? Surgery, chemotherapy, radiation, and something called as immunotherapy. Surgery is very simple. You can remove the tumor. Something that I always ask in the exam is that for surgeons to do surgery on the lung, FeV1 should be more than 1.5 liters. Please remember this. I deal with this on a day-to-day basis. If patient's FeV1 is less than 1.5 liters, patient cannot undergo full pneumonectomy because he will get stuck on the ventilator and not be able to come off the ventilator. So for surgical treatment options for lung cancer, we must have the option, we must have documented PFTs with FeV1 more than 1.5 liters. That's why anybody who goes for lung surgery must have PFTs, case closed. In surgical options, we can do one lobe of the lung or the whole, remove entire lung. Resection can be done depending upon the extent of the tumor, as long as the disease is inside the lungs. It can be tumor and its lymph nodes are inside the lung. You can do a segmentectomy, lobectomy, or pneumonectomy. FeV1 more than 1.5 liters is what you need to do. What about the chemotherapy? I will never ask the names of the medications on the exam, but this is something you need to know. Most of the treatments is cisplatin-based therapy. Then, as I mentioned, we look at the genetic mutations. EGFR mutation will get a different kind of chemotherapy. It's called as tyrosine kinase inhibitors. No need to remember the name. If it is ALK mutation, it is crizotinib. Or if there are other tumors available, some other kind of treatment may be given. If patients have high PD-L1 levels, immune checkpoint inhibitors can be given to our patients. So chemotherapy is standard chemotherapy, genetics-based chemotherapy, or immunotherapy, which is immune checkpoint inhibitors can be given to our patients. Gone are the days in which patients will get everybody gets the same chemotherapy. That's not the case anymore. Everybody gets a different kind of chemotherapy based on whether they have small cell or non-small cell, and also based on their genetic mutation analysis on PD-L1 program, cell death ligands population. Very complicated, but very interesting. And then you have radiation, which can be given through external or through bronchoscopy. These are some of those tumors as we talked about. Stage 1, The small lesions here, small lesion here, remove it, lobectomy. Stage 2, the lesion has been removed. Stage 3A, this is the tumor. You can give chemotherapy and then remove it and things like that. Stage 3B and stage 4, chemotherapy plus minus the genetics pharmacogenomic therapy or immunotherapy is given to the patient. If you've been sleeping and found it to be difficult, this is the summary slide. Stage 1 and 2 in non-small cell cancer, you will do surgery. Stage 3, you will do, it may be chemotherapy followed by radiation. In stage 4 tumors, these are extensive disease in the lungs and other places. You will do chemotherapy based on the documented mutations or immunotherapy for these patients. That's all I want you to remember at this point of time. Nobody's asking you the name of the medication. Stage 1 and 2 surgery, stage 3 chemo plus minus radiation plus minus surgery, stage 4 no surgery but specific chemotherapy. It can be standard cisplatin, it can be targeted therapy based on genetic analysis plus minus immunotherapy. 1 and 2 surgery, 3 radiation, chemo, and adjuvant immunotherapy, stage 4, no surgery, but targeted chemotherapy, immunotherapy, and supportive care. For metastatic lung cancer, non-small cell lung cancer, the goal is to improve the survival. We do the molecular testing, we'll do these mutations, etc. And we give them treatment based on these results. If none of these mutations are present, we can go standard chemotherapy plus with some immunotherapy, etc. The point is, there are 3 kinds of chemotherapies. Standard chemotherapy, cisplatin, based on genetic analysis, that's targeted therapy and immunotherapy. So 3 kinds of therapies are available. Chemotherapy, targeted therapy, immunotherapy. These are 3 treatment options for stage 4 cancer at this point of time. I talked about the EGFR mutations, which are present in adenocarcinoma, that these can be done. Immunocheckpoint inhibitors for patients with PD-L1 and other kind of treatments, which is PD-L1 is present on the cancer cells. If it is very high in density, then we can give immune checkpoint inhibitors to basically, this time we are targeting, just like in asthma, we block the antibodies. This time we block the PD-L1 receptors on the cells so that they die out. What is the prognosis? Stage 1, non-small cell cancer, 5-year survival, 80%. Stage 2, 50%. Stage 3, 25-30%. Stage 4, less than 1%. So you can see when surgery is involved, generally survival is good. Chemotherapy, radiation, stage 3, okay. Chemotherapy, radiation, targeted therapy, and immunotherapy, not much of an option even today. So what about small cell cancer? Small cell cancer is either limited stage or extensive stage. If it is limited stage, surgery may still be possible. But if it is extensive stage, no surgery. You have to give chemotherapy to these patients. And here is the survival. Limited stage, even with the best surgery, 10% 5-year survival. Very poor. Extensive stage, I've not seen anybody go more than 1 year. I've been doing it for 30-35 years. So the prognosis of small cell cancer is still not very good, people, despite all the advancements that have been done. How do we screen for people? So the fun thing we can do is to catch people in stage 1 and stage 2 when the tumors are early or limited stage small cells, so that tumors not outside the lung. We do that by screening CAT scans. The recommendations are anybody above 50 years of age till 80 years of age, those who are active smokers and have smoked at least for 20-pack year history, they should get a CAT scan of the chest every year. CAT scan of the chest every year. So if there are lesions show up, we follow them. And then if they're increasing in size, we remove it. So that's how you pick up early cancer. If you pick up early cancer, you remove it through surgery, the prognosis will improve. As I've shown you, whether it is late stage, extensive stage small cell, which is treated with chemo, or extensive stage non-small cell cancer, which is treated with chemotherapy, treatment, genetic-based treatment therapy, or immunotherapy, no treatment is good enough, and survivability is not very good in these patients. Let me divert you to a little bit different aspect that we deal with, and it comes in the exam all the time. What about solitary pulmonary nodules? Please don't show up to the exam without knowing what's a solitary pulmonary nodule. Wake up now. I know it's the end of the day. A solitary pulmonary nodule is a nodule, one lesion in the lung, which is less than 3 centimeters in size. If it is more than 3 centimeters, we'll call it lung mass. Solitary pulmonary nodule is less than 3 centimeters in size. It is completely surrounded by pulmonary parenchyma. It is not associated with any lymphadenopathy, atelectasis, or pneumonia. I bring this up because we see many solitary pulmonary nodules every day. Does that mean every patient that I see who has a solitary pulmonary nodule has cancer? Answer is no. Most of the solitary pulmonary nodules are benign. Does that mean that anybody who has lung pod nodule should undergo a resection of the lung? We would be doing a lot of negative lung surgeries. So how do we approach it? As a healthcare provider, you must know this very, very well, because I'll ask it in the exam, it is also asked in the boards, but it is practically important to know. How do we counsel a patient and figure out whether this is malignant or benign? One thing I told you, do a PET scan. If it is positive, remove. If it is negative, don't remove. That's one way of doing, but I already told you false positive negatives may occur. So we look at a patient, we look at patients, solitary pulmonary nodule present, yes, okay. We look at patient's age, smoking history, family history, and if he has a past history of cancer. Age, a solitary pulmonary nodule in a 20, 30 years old is generally benign. It's probably infection-related scar. A solitary pulmonary nodule in a 70, 60, 70, 80 years old person, which has just developed this, is probably malignant. So as the age increases, the probability of malignancy in solitary pulmonary nodule increases, and this will come in the exam. If I were a smoker, if I'm a smoker, probability of malignancy in a solitary pulmonary nodule increases. If I have a family history of lung cancer, or I have a past history of cancer, chances this solitary pulmonary nodule being malignant is high. So these 4 factors you should know. Patient's age, patient's smoking history, patient's past history of cancer, and patient's family history of cancer. And this is how I want you to see. So this is how we give the probability. Solitary pulmonary nodule, these are all my real patients, as you can see, a nodule here and a nodule here. If patient is young, no smoking, no cancer, nothing, chances are benign. But there is one characteristic of the lesion that you must know. If it is round like a coin, chances are it is benign. If it has radiations coming out, it is malignant. So 4 things in the history: patient's age, patient smoking, family history, history of cancer, then characteristic of the lesion. If it is round, benign. If it is irregular, malignant. And remember, we talked about the lung cancer is more in the upper lobe. So a solitary pulmonary nodule in upper lobe is more chance of being malignant as compared to the one in the lower lobes. I don't want you to think that Dr. Talwar thinks everybody has cancer who has a nodule. No, most of the nodules are benign. And for the exam, the commonest benign tumor of the lung is a hamartoma. commonest benign tumor of the lung is a hamartoma. Okay, but lipomas, nodules, sarcoid, tubercular, histoplasmosis, coccidioidomycosis lesions, bulb abscesses, other causes, cyst. There are many causes of benign lesions in the lung. That is why before we send patients for surgery for solitary pulmonary nodule, we go through an algorithm of history, the 4 things I talked about, look at the size of the lesion, location of the lesions, and then we decide whether this needs to come out or not. Most of the time, we do nothing. We just say we need to follow you closely. Here are some of those lesions. This one I showed you before, as has radiations coming out, it was malignant. This is slightly globular looking. It was benign. Here, this air bronchogram in this is probably benign. You see how nicely rounded this is, benign. This one is removed and this benign, and this one as well. It was a hematoma. And just to recap, another patient of mine, first time I see her in 2016, I said, listen, this is some abnormality here. She said, nothing doing, doctor. I'm not going anything else. Comes back 2 years later and I say, oh my God, this area has increased in size. I do a PET scan, it's picking up. It's very SUV, standard optic value is very high. It was a cancer. So you see, when in doubt, you follow the patient. You follow with repeat CAT scan, 6 months, 1 year interval, to make sure the lesion is not increasing. And if on repeat follow-up, the lesion does not change over 2 years' time, 2 years' time, you can tell your patient that your lesion is benign. If it changes in 2 years' time, even by 1 millimeter, you have to have it taken out because there's probability of malignancy. So first 4 histories, then you look at the location of the tumor, upper and lower lobe, then you look at the characteristic of the lesion. And if you decide to do nothing, we must follow those patients, and these lesions must remain stable for next 2 years' time. If not, anytime it changes, we remove it. So low probability, you will follow them every 6 months. Intermediate probability, you probably do a PET scan and follow them more closely. High probability, you excise the lesion. Okay. What about carcinoids? Carcinoids are neuroendocrine tumors. Most commonly, the carcinoids in the appendix or in the GI tract. But carcinoids can occur in the lung as well. When carcinoids occur in the lung, it is more common in females. It's usually an endobronchial tumor, and sometimes it will cause hemoptysis. Sometimes it will lead to bronchiectasis because it blocks the bronchus. I showed this lesion before as well. The carcinoids are usually in the airways, and if it is there, they need to remove it because it causes hemoptysis. Carcinoids don't metastasize. It's a very slow growing tumor. It does not metastasize usually. Most of these patients will have a little bit of hemoptysis. Now I want you to know this. We believe small cell cancer is a variant of carcinoid. It's also a type of neuroendocrine tumor. But carcinoids per se are solitary lesions in the lung which do not change over a period of time. Generally, it's present in middle-aged or elderly women. You will see a solitary nodule, or you will see it in the airways. If it's not having hemoptysis, otherwise stable, we just follow it. Very rarely, carcinoid of the lung may metastasize or maybe have more activity, or it may be metabolically active. In those cases, you will have a history of tachycardia, flushing, bronchoconstriction, etc., etc. So actual carcinoid syndrome occurs very rarely from lung carcinoids. Lung carcinoids are generally benign, very slow growing, rarely metastasize, and metabolically inactive. But very rarely it can cause carcinoid syndrome kind of features. And if it does, we will remove it. The triad for carcinoid is endobronchial lesion at the bronchus with eccentric calcification. This is a typical triad. An endobronchial lesion at the bifurcation of the bronchus, the eccentric calcifications. Those patients who have a little bit atypical carcinoid with malignant features, after the resection, we give a medication called as everolimus. Everolimus is the only treatment post-resection in those patients who have active carcinoid lesions we will give. So folks, in my mind, I've taken you through a journey today of two very different diseases. We covered the airways very nicely. We looked at bronchiectasis. Then we looked at the lung cancer and we looked at the two types and we defined its features. Paraneoplastic syndrome, we talked about the PET scan. We looked at the resection criteria of FEV1 more than 1.5. Then chemotherapy based on standard genetics and immunotherapy. I keep reminding it because kids keep getting confused with it. 3 types of chemotherapies are available. This is for stage 4 disease. Standard type of treatment. In this, you will give the standard treatment or based on genetic analysis, targeted therapy. And if the genetic, this is negative, we also measure sometimes called as PD-L1 levels, which are present on the cancer cells. These are the proteins present on the cancer cell, which allow it to evade its recognition. So we give immune therapy to kill these cells. So today, when you talk to somebody, I want you to look smart and know, yes, there are 3 kinds of chemotherapies for cancer cells. One standard treatment, which will kill any cancer cells, but not very effective. Then targeted based on genetic analysis. And then third one is called as immunotherapy. Immunotherapy is used for stage 4 cancer cells treatments when nothing else is possible. Then we talked about solitary pulmonary nodule and spent a little bit of time on that because it is important to know about it. Solitary pulmonary nodules, the way we look at it, how do we define it? How do we figure out what needs to be removed? I gave you a little bit of thoughts on that. They'll all come in the exam. The definition of solitary pulmonary nodules, a lesion less than 3 centimeters is important. Then we talked about a rare tumor, which generally presents in the endobronchial area at the bifurcation, causes hemoptysis, may cause bronchiectasis, generally is not active and does not metastasize. But if it does, or it has a metabolically active on biopsy, you would give everolimus to the patient as the treatment after resection. Any questions on lung cancer at this point of time?
Professor, there were more slides that were different than usual. Would it be possible to email me this?
Send it. I don't know why this is happening. I got one email. I'm going to send it both these slides just now so that you all have it. Okay.
Great. Wait, so what if I emailed you and then you'll have my email and you can send it to me?
I have one email, but you can send me another one. Just send me one, please.
Okay.
And I want one of you to stay or everybody to stay. I want to make sure everybody gets these slides. This is not acceptable to me. That I spend so much time updating the slides and they haven't reached you guys. That's just not acceptable. Okay, just 1 second, please. Just give me 1 second and I'm going to minimize this. I'm going to minimize this. I'm going to minimize this. Am I sharing my slides? I don't know. Stop share. And let me just stay there, people. Let me just send these slides because I want to make sure everybody has it. Okay. I'm sending the bronchiectasis slide sent, and I'm gonna send this again. I've sent it. Can you guys hear me? I've sent it. Please confirm that you got it.
I received the lecture 7 of the bronchiectasis, but I did not receive the. Oh, okay, perfect. And I received the lung cancer one as well.
Okay, so you have it. You can distribute it to the class.
Yes, of course. Thank you so much,
Okay.
Professor.
The next lecture is on Tuesday now. Is that right? And 5:30 to 7:38 or something like that? Yes?
I could check.
Check, please.
Yes, on Tuesday from 5:30 to 8 p.m. and it says we're
Yes.
on Zoom.
I'll try to get this earlier slides as well.
Okay, amazing. I really
At
appreciate
what
it.
stage most large cell cancer is usually found, and at what stage do they most often become symptomatic? Large cell cancer is a slow growing tumor, but it is ubiquitous. It can be a little bit asymptomatic initially, but then when it increases in size, it comes back with either pleural effusion or a metastatic disease. So I cannot give you one specific way to think of it. It is less between squamous cell, adenocarcinoma, large cell. I want you to think of it. The adenocarcinoma goes faster, squamous cell less, and large cell cancer less than that. But it does become symptomatic. And when it becomes symptomatic, it comes with a vengeance. So it's a little bit different. But the good part is large cell cancer is around 10 or 15% of all the non-small cell cancer. It's not that common. I hope I answered that question. Okay. Any other question, please, before we go away? Can you guys hear me? Yes or no? All right, people, I'll see you on Tuesday now. Thanks much.
Good night.
Bye-bye.